Dr. Tom Hill, thanks very much for joining us.
No worries. Thanks for having me.
Take two, we just realised the camera wasn't recording, which
All
is...
my A material's gone, so...
we'll have to try and rehash it out. But my first question was, and still is, sports medicine in today's society, as it's technically, we talked about it before, modern sports medicine, how's it changing in the world today?
A lot. And I think what we were doing in the sort of 90s and early 2000s looks vastly different to what we're trying to do today. And medicine broadly is evolving and expanding and you know, across every line. But for us, we're now sort of starting to move to a space where everyone is thinking forwards and everyone is trying to work out ways that they can stay active and healthy later on in life and increase quality of life as they get older. And some of that is trying to avoid things like unnecessary surgery and things that might actually not be in your long-term benefit. And sports medicine's now starting to fall in that landscape of somewhere between a GP who might see you and kind of get your pain under control and get broad strokes started. And then if things aren't getting better with the fundamentals, often the conversation then moves to, well, you know, you need surgery. So that might be a knee replacement, hip replacement, you need to clean up in your shoulder or whatever. And so the role that we're starting to take is finding those patients who sit in limbo and who sit in between, who are not getting better with the fundamentals, aren't bad enough to go and have the surgery, and they kind of just get lost in the system a little bit. And that's kind of a big chunk of the space that we're trying to operate in our day-to-days. So, it's a difficult population because the problems are usually complex, but there's a lot of people who live in that space and they're trying to find, ways that they can manage things. And it's not always necessarily curative, but they're trying to find ways to improve quality of life without going to extremes.
Because a lot of people think that sports medicine is just for athletes and not for the regular person like myself who's recently been doing some work with you. And is that stigma something that's kind of washing away slowly?
Yeah. It's a work in progress. So it's actually a big barrier for us in sports medicine is that people, obviously from the title, but our college changed its name from the College of Sports Physicians to the College of Sport and Exercise Medicine Physicians a couple of years ago to try and kind of expand that title and to make sure that people didn't feel like we were trying to filter to the elite. Because my life is usually in two different components. So I live in professional sport for half my life, and then I live in the clinic where, you and I hang out, and they're very, very different spaces to work in as a doctor. So in my normal job, in terms of the clinic sense, what I'm often seeing is recreational athletes, yes, but I'm also just seeing people have sore bits and pieces, a sore knee, sore hip. I mentioned to you like a 10-year-old who had sore elbow playing tennis, and then I have a 92-year-old lady with a sore shoulder that wants to lift the great grandkids. And people who come in and see me in my general day-to-day clinic, they often kind of get intimidated by the fact that we're sports doctors, and they try and as we were sort of talking about before, like they try and put on their old WAFL footy shirt and do all these things to kind of make themselves fit into the model that they think we are. But by far and away, the most common thing that I manage is something like an arthritis or, I seem to see a lot of 50, 60-year-old ladies with gluteal problems and bits and pieces that are just kind of sore day to day or sore sleeping and they're nowhere near a sporting field.
Okay, well, that being said, with the high performance athletes, how is it evolving in the world today? How is it changing on a day-to-day basis?
So that world is definitely changing, and the stuff that we do in professional sport is a lot of it is trying to work out educated risk, and we're trying to work out what we're going to take on for performance, and then what the trade-off is for not only quality of life in that phase for them, and the rest of the season or the rest of their career, but we're also trying to think about what's best for them for the rest of their life and their families and their kids and, forecasting forward. So I think a lot of what is advancing in professional sport is we're trying to eke out those couple of percent. So there's big money and glory that waits for the team that can etch out an extra 5% advantage over the competition because everyone's getting so good and everyone's doing all of the things that we thought were fancy 10 years ago. That's just accepted fundamentals now. So we're always trying to find that next thing, and we work as a unit, so that they're often called kind of triple SM. So sports science is sort of a bit more of a collective term for us, and And that includes, myself as the sports doctor. We've got physios, often multiple. We've got strength and conditioning. We've got dietitians. We've got psychologists. And then we've got, player wellbeing managers, and it all kind of forms this big network. And from my end, what I'm trying to do is I'm trying to kind of help these players work out where to spend the risk, because an injury for a hammy for a professional athlete is very different to an injury for a hammy for you or I. So you or I, if I say, take it easy, nice and slow, and, you'll be back running park runs in 6 to 8 weeks, you don't blink, it's not going to affect your life. But if I say that to someone who is maybe, an important player, or someone who's got a really important career opportunity and this is the last season of their contract and they need to take that on, you spend risk differently. And something I'm really passionate about and I'm really big on, and hopefully I've kind of passed that on to a lot of the players and the coaches, is that decision has to be done with the player in mind and with the player as part of a conversation. So if they're going to take a risk on their well-being or on their careers or on, how their knee might be in 10, 15 years' time, as a result of actions you take today, they have to be part of that conversation and they have to have ownership of it. So I just kind of steer the conversation and give my advice, but ultimately, whenever I can, it's very different with things like concussion and stuff like that, but whenever I can, I try and give players autonomy to take risk, so long as it's, it's accepted by everyone.
Yeah, awesome. And the way sports medicine's evolving, is it a change for good, you think?
Yeah, I think it is. I think we're starting to eliminate a lot of the people who are sort of flirting on the boundaries of drug use and all these bits and pieces. Like, everyone's always going to exploit the rules, and the sports that I live in and work in, and mostly cricket, but I've done bits and pieces in footy and some other stuff, but those sort of codes and those sports are actually what we're trying to do. We are trying to go into it with an ethical mindset, and my experience in general is that I really don't have a lot of problems with people trying to abuse drugs and bits and pieces to try and gain competitive advantage. But sports medicine does lend itself a little bit to exploring small percentages and fringe medicine and fringe management that might not necessarily have all of the evidence. But again, when we're chasing small percentages, sometimes you do things, and you see it in cycling and you see it in tennis, and all of these kind of sports go global when they have their big corruption scandals. But I think that's the murky part of sports medicine, is when you're trying to find small percentages, to what expense are you willing to go, and what are you going to risk in terms of cheating, and what are you going to risk in terms of player welfare and treating them as a human being first and as a player second. So are you going to use a certain drug on a player that might be completely legal but might actually expose them to having issues acutely or down the line, and it's really blurry. So I think in cricket we actually hit the sweet spot really well, and we're governed really nicely through Cricket Australia, and we all try and have a similar mindset, and we're certainly trying to find advantages, but we're trying to kind of do things safely and make sure that we respect the players as humans.
Because you see, with just the medical industry in general, it takes a long time for change. Like, patterns have to be followed, there has to be lots of studies done, and medicines have to be approved by regulations. Does sports medicine, being like a newer sort of industry per se on the scene, does that make it a lot easier to get better, more innovative ideas out quicker?
It doesn't. It actually impedes us, because a lot of these options for sort of exploring new management techniques and treatments, they need studies. And when you're a small college and you don't have the numbers and the weight and the power, it's very hard to get those studies done. And when you do get them, it's very hard to get them big enough and strong enough to then drive change and stimulate, regulation changes and things like that. So I actually think we're a little bit hamstrung sometimes by being a smaller college. But the luxury we do have is that because we are a newer college, we're not necessarily drawn back into historical management. So
I would like progressive.
Yeah, I'd like to think, as a general rule, sports medicine is a pretty innovative area. And lots of the time, and even in my clinic, like I meet a lot of complex patients, and by design, unfortunately, but fortunately, we get put in this position where we see people who have seen, a GP, a couple of physios, probably an orthopod, and maybe some allied sort of medicine, chiros and osteopaths and bits and pieces, and things just haven't kind of been nutted out, and you're trying different things and you're exploring alternatives that might not actually have, clear boundaries, and you're going a little bit left field. And I really enjoy doing it, but you're always kind of playing in a bit of a sort of a fringe space in medicine that might not necessarily have all of the literature reviews and things. But so long as you have a good understanding of what you're trying to uncover, and a lot of the time for players and patients, it's just important that you're thinking about safety profiles and bits and pieces when, you're getting a little bit beyond mainstream.
Yeah, because as well, Australia as a whole versus the other countries and where we sit, you hear stories about Eagles players flying off to Dubai to go get checked out, or LeBron tearing a tendon in his foot and going to Germany to go get that fixed to have it be playing again within a month for playoffs, or people going down to Mexico to get stem cells. Yeah. How's Australia sitting compared to other countries when it comes to
We're very conservative. Yeah, we're very conservative compared to those countries, and we do have sort of probably stronger regulating bodies that kind of govern what we can and can't do. But I think it's a good thing, all of those options exist. And so at the moment in Perth, if you want to go and have stem cell treatment, it's able to be done, and you're not going to some dark back alley and, someone's doing something dodgy in a vet.
In Cancun, Mexico.
Yeah. So it can be done, but, there's not too many people doing it. And stem cells is a good example because people kind of know about it. But that is going to be probably the future of sports medicine and a lot of regenerative medicine, and it's going to change the way that we do things like hip replacements and knee replacement if you're regrowing cartilage and bits and pieces. But we're kind of still waiting for that to be played out in an evidence-based world. So at the moment, the evidence doesn't sit there. And so when the evidence doesn't sit there, that doesn't mean you can't do things, but it does mean that you've got to weigh that up, and you've got to kind of have those conversations about what you actually are doing and what the risks are. And so that's kind of a big driving factor, particularly for us in Australia, is that we probably have that discussion a bit more broadly, whereas I think people can often, and we talk about chasing the gurus a lot in sports medicine, and so, flying to Germany and getting, some weird sort of
LeBron James of feet doctors.
Yeah. And so, good on him, and he's, he's an incredible guy, and what he does at his age to that extent is, otherworldly. But for every LeBron James, that sometimes he's obviously a supreme talent and generational player, but for every LeBron James, there's a lot of people who would try to kind of, keep up that sort of pace and athleticism, who just, no matter what you do, no matter what you inject, that's actually not how your biology is going to work as you're, 40 years old. So yeah, I think it's an interesting space, but where Australia is a little bit more conservative, and you're always kind of weighing up risk benefits and making sure that you're not exposing yourself to problems down the track in things that haven't been studied.
Would it be possible to estimate sort of the future for how long it will take to get there, or it's way too hard to tell because it's too early stages?
It's definitely getting closer and closer. I have patients come in all the time who want to talk about what they're, and we sort of call them adjunctive treatments. So they want to talk about, what can you do for me that isn't surgery but is going to try and stimulate change. And so this is where things like PRP come into discussion, and that same conversation is often drawn back into, what are stem cells doing, and where's that space at? And the conversation I generally have is I actually think, my belief is that in the next sort of probably 10 years that's going to advance to the point that it's being used fairly mainstream. As I said, you can do it now. The evidence isn't quite there and the studies aren't quite powerful enough, and we haven't worked out how we can kind of manipulate to make sure it's safe but effective, and also being cost effective as well. And this is a bit of a trap for a lot of these treatments, is that it's all well and good for LeBron, to go and source out the guru, that's a drop in the ocean. But if you look at things like stem cells, if we're going to kind of do something that costs you $5,000-$10,000 straight off the bat, and that's not including all your other bits and pieces, you want to have confidence that it's going to work.
Yeah.
So for some people, not a problem, try everything. For a lot of us, it's probably not realistic. So, that kind of comes into conversations as well.
So at your current practice, some of the things you do today are things like PRP, cortisone injections, N-stride injections. Yep. How progressive are they, and how do they basically work?
So cortisone injections is and these are steroid injections. So that's been done, since the dawn of time, and it's something that's probably becoming less and less common. And it used to be the fix-all for everything, and now we're kind of trying to understand where its place is. And most of the stuff that we're looking at is, well, what's the long-term impact of this? So we definitely still do it, and it still has a role, but the days of kind of recurrent, repetitive steroid injections into joints is probably dying off a bit. And we know that in the long run, that can thin cartilage and can worsen arthritic change. But it still definitely has a place for people for pain modulation and sort of down-regulating inflammatory cycles and things like that. And it's used a lot for us in rheumatology and all these other things. But the space of PRP and NSTRIDE, which is a sort of variant of PRP, so this kind of regenerative medicine and biologics that we sort of talk about is evolving on the back of people being a little bit hesitant to just run down the steroid pathway and go, well, what else can we do? And so PRP is basically taking blood, and we usually take it from your arm, we spin it around in a centrifuge, and there's lots of different methods and ways to manipulate it, but essentially we're taking your biology and we're trying to concentrate your platelets in a small bit of plasma, and then we're injecting that into somewhere that we want to stimulate some sort of a healing response. And the way that you do that is variable. And this is a problem with a lot of the literature, is that it's very hard for us to prove what is the gold standard for PRP. And this is why the evidence is often a bit mixed, is because your platelets are different to mine. And the way that we kind of prepare it is often different. So drawing lots of studies together just isn't realistic. But the essence of what you're trying to do is you're basically trying to give something a healing environment and stimulate it to get some sort of repair process underway. So we use it for chronic tendon tears. We use it for little bits and pieces that have sort of failed healing along the way and have become sort of, chronic grumbling, niggling injuries. And we also use it for things like arthritis. And again, there are a lot of papers that'll show it sort of sits on that fringe and that borderline, and evidence is mixed, and you just got to make sure that you're picking the right patients and you've got the right pathology. You're trying to achieve the right outcomes, and also, you're backing in biology. So I often get people who are, 70s plus coming in and they want PRP of their arthritic knee. And the reality is, the arthritis is really advanced. So you're asking a lot. And also their biology isn't the same as yours. Your body's not working the same way. So things are always, tailored to the individual. But that space and that kind of use of biology is really interesting. It's something that I really enjoy and something that I do quite a bit of in clinic, because I think for me, an evolution of sports medicine is that we're trying to find ways to manipulate biology, because we're brilliantly designed, but how can we tweak our own systems to be able to do a lot of the job ourselves rather than relying on synthetics? So, it's an interesting space, and it's always evolving, and it's something that we're involved in sports medicine. But there's also a strong part of what we do is people coming in for adjunctive treatments and injections, but they haven't nailed the fundamentals. So for me, you've got to prove that you're not going to get better with the basics. So, have you done your strength-based rehabilitation program? Have you modified, if it's a repetitive overuse, have you actually modified what you're doing? Are you just kind of shoveling holes, 12 hours a day? I had a guy who I was talking to yesterday, and he's a truck driver, and he spends 14 hours a day in a truck driving, and he's got disky back pain. And it's like, that's really hard to manage. So all the interventions and bits and pieces in the world are going to struggle when he does that 6-7 days a week. But the hard part for a lot of people is that that's their livelihood. That's how they earn money, and it becomes a really complex thing.
Yeah, because me personally, I'm obviously being treated by you at your clinic.
Yeah.
And when I first came to you, I had shoulder problems. I'd done a bunch of rehab. Nothing seemed to be working. And I came in, and then you told me all these options like getting PRP, and I never even thought about it. And it's not too expensive either.
No.
Pretty accessible to the average person. And I was very surprised by that. And I really liked how the way you explained it with you could go and get surgery, or you could try this first. And I was really on a anti-surgery approach because it was cartilage in my shoulder, and I didn't really want to mess with that too much, because I've seen people who've done cartilage surgery on their shoulder and just keep redoing it.
Yeah.
So that was, to me, it was really almost was a sigh of relief.
Yeah. And that's like your case is a really good one, because that's a really common thing, and people who aren't aware of us probably never get the opportunity to come and explore these things. But I try and make a bit of a point of trying to keep it accessible, and so prices obviously vary. But when we were talking before about stem cells, and it's a sort of fringe alternative, and that's a very different very different prospect if you're talking about $5,000-$10,000 as opposed to something that might be $300-$400 and is readily accessible. Is done in half an hour. Again, risk profile, you're talking about using your own biology, so it's actually quite low. That I think in a situation like yours where you're going, well, yes, there are surgical options. They're not a home run fix. It might not actually make me better. It might make me worse. What else can I trial? To me, if I'm you and it's my shoulder, I'm trying all the other bits and pieces. So long as I'm not going to make something worse and change my surgical options in the meantime, and I'm being carefully managed and I'm doing all the right things, I think it makes a lot of sense to kind of play around in a space that has a low risk profile, but it might have a chance of getting me out the other side without all of the bits and pieces that come with surgery.
So surgery is almost like cortisones, where it's been a time-old thing, but it's slowly becoming less and less used as these options are lower risk and better.
Yeah, big time. And don't get me wrong, like I obviously I work at Perth Orthopaedic and Sports Medicine, so I work very close with a lot of orthopaedic surgeons, and they're incredible, and some of the stuff that they do is really, really vital, and it changes lives. But medicine and history are showing us that we are finding historical things that used to be done that are probably causing more harm than good. And like the classic example is going in and doing cleanups on arthritic knees. Like that just used to be bread and butter for a lot of guys. And 20 years ago, that was still, they're rolling out 20 on a surgical list, but that's few and far between now. And the indications to go and do that are less and less. And a lot of surgeons will see that you've got an arthritic knee, the GP sends you to come and get a cleanup, and they'll actually send you to go and see someone like me who sits in the in-between, because the surgeons don't necessarily want to do it because they go, well, you're 50 and if I go and do your cleanup, I'll make you better for 6 months, but you're going to need a knee replacement probably in the next 2 or 3 years. So go and explore all your other bits and pieces. Have you lost weight? Have you got strong? Have you tried the adjunctive treatments? Go and do all that. And if we get you into a happy space, you're off and going. Otherwise, yes, I do have an option. So it's really nice. And the guys that I work with at Possum are great at that. And we kind of collaborate a lot of the time. And sometimes it's just an opinion, because sometimes people get sent to see me and I actually say, I saw someone the other day, and one of the sort of things that we came to at the end of our consult was, you're not for me. Like, you need a hip replacement. I think you'll be really happy with the hip replacement, but you've done X, Y, and Z, and your arthritis is so advanced that, I think there's a good chance we spend 6-12 months with you still sore, you're still unable to kind of do the things you need to do with your kids and in your life, and a hip replacement will actually functionally serve you really well. So, it lands on both sides, but yes, surgery definitely was something that was just seen as a cure. But now we're starting to look at it as a bit more of a holistic thing and working out, well, what are we taking on in the long run?
So focusing a bit more on you, your educational background to this, you grew up in Tasmania.
Tassie, yeah.
And then you've come over here, but going through medical school today, is it progressive, or is it looking at all this old stuff that's not really used today? Or
No, the medical degree is changing a lot. And so I was 18, I think, when I started. I did an undergrad, and that's phasing out. So a lot of the courses now, you're doing it as a postgrad, and I think it's a good thing because you come in a bit more mature, a bit more rounded. And there's a lot of people who probably aren't suited to medicine, and it was a bit like myself, and I got lucky. But you finish school, you get a nice score, and it's just this assumed thing that you go and do medicine. Is like certain scores, you go and do medicine, but medicine as a lifestyle, if that's your occupation, is a very kind of unique thing, and you've got to be committed to lifelong learning and education, and it's not suited for everyone. But the modern degree is really good and I was kind of in the first wave of it, and they kind of have moved away from a lot of the historical basic sciences, and now they're kind of trying to make it more clinical from the start. So, I still remember my first lecture that I ever went to. The lecturers got up and they did this kind of mock cardiac arrest up the front. And it was a bit cringe, but you're like, well, this is a very different thing to I thought I'd be sitting in a sciencey lecture on mitochondria and all this stuff that you're going to finish and you're not really going to care about. So you get that, but a lot of the focus now is on clinical correlations and what are you actually seeing and what do the patient cohorts look like, and it's really good. I think it's evolved a long way, and I think we're trying to come out as much more rounded doctors who can then kind of integrate into the community and actually impact change rather than being scientists.
Yeah, because did you always know you wanted to be in medicine, or?
No, I was lucky. So I was one of those weirdos who finished with a good score and just kind of ticked the box of what do you want to apply for. And I actually think my mum put in my applications, to be honest. I was playing video games or something, and she was like, "What do you want to do?" And I was like, "Oh, put medicine in," which is a horrible way to choose your lifelong career. And then I actually deferred, and I went away, and I spent a year. I did. I was a housekeeper on Hamilton Island. I was a barista, pumped some gas at a BP, and I just kind of went and did all these, bits and pieces, and kind of worked out, right, well, I want to go to uni and I want a career, and I realized that I wanted a career where I came out with a defined role, which medicine is a little bit like that, but some of these degrees you come out and you're not necessarily going into a commerce degree or bits and pieces. It's not as funneled, but I kind of like that. So I kind of fell into medicine that way, and then it was a weird thing. So growing up in Tassie and doing medicine, there were only 2 sports doctors in the whole of Tasmania, and I'd never seen them, never heard of them, didn't know it was a specialty. And I actually got all the way over here, did my internship, did my residency, was training in orthopaedics before I even knew sports medicine was an option. So, and that's how far it's come, but that's where it was. Like, I'm in medicine and I didn't even know sports medicine was an option. And then I was working with a plastic surgeon, and his brother is a sports physician, and he was chatting to me about it. I thought, this sounds like what I want to do. And so I remember I actually called in sick for a day as an orthopaedic registrar, and went and sat in with this guy's brother for a day, and I just watched what he was doing in clinic. I thought, this is it. And that was kind of how I ended up in sports medicine. But yeah, I think my journey was a bit lucky along the way. It's, as I said, it's not for everyone, and you've got to kind of commit yourself to that lifelong learning and this whole kind of experience that comes with the responsibility and the pressures of working in medicine.
I really like, though, how you talked about how you deferred and went off and experienced a bunch of things to decide what you want to do, because we talked a bit about it last week's episode about a guy who's started off at uni doing commerce, hated it, deferred, tried to be a pilot, went and did a bunch of stuff.
Yeah.
And then he was like, actually, I want to go to uni. And now he's doing business information systems at Curtin.
Yeah.
So, and we kind of talked about the advantages of going out and experiencing a bunch of things and taking a bit of risk in your own life, and then not living with regrets when you decide what you want to do.
Yeah. And it's scary. And I think it's good now that it's moving to postgrad, because as an undergrad, as an 18-year-old, how do you know what you want to do?
Exactly, yeah.
And I had no concept of what medicine was. I just thought, that's where people with nice scores go in, they get nice careers, and life's good. And, you end up on scrubs. But it's such a different world, and I think you probably go into it as a postgrad with a better understanding of what you're taking on. But yeah, I'm really glad I did what I did in that year off. And I have people I talk to, and patients, and often parents come in, and I'm treating their kids, and their kids are, sitting there, and they're asking about what's medicine like and what's sports medicine like. And I'm always kind of really supportive of taking a year to go and find yourself, work out what real life is like, go and work in a sort of normal 9-to-5 and work out how it all fits in. And there are probably some people who go and do things like that and then think medicine's not for me. And I just think you kind of find yourself and you work out how you tick a lot more once you leave home, go and do something different, put yourself in some vulnerable situations. One of my jobs, I was working as a telemarketer for a group called V8 Mortgages. So I was selling mortgages. Well, I didn't even have to sell the mortgage. I had to get an expression of interest for someone to call them back. And my shift was, I think, from 4 p.m. till 7 p.m.
Is that just cold calling?
Cold calling mortgages at dinner time.
How old were you?
I was 18. So
That's daunting.
I just finished school. I moved to the Gold Coast and I was selling mortgages, and it was actually really fun.
Pretty handy skill to pick up as well.
Yeah. It's a bit slippery, but it was fun. But my God, like the abuse you'd cop on the phone and the way people would treat you. And it's I actually, when telemarketers call me now, I'm a little bit softer. I'm like, I used to have people just say some of the most horrific things, but it's you go and get those life experiences and that you wouldn't get otherwise, and you kind of work out how the world works and what you want to achieve and what you want to do, and have a better appreciation of how everyone kind of fits in. And I think I'm really lucky that I just happened to choose to go and do it.
Because you've almost got the perfect balance with the half in clinic practice and the half with sports teams.
Yeah.
And you started with East Fremantle Football Club?
Yeah, Sharks. So yeah, that was my first ever gig, and I was a resident at Freo Hospital. And yeah, I don't actually know how I fell into it, and I was really junior. But I just remember someone was looking after Subi, and they say, "Hey, can you help out at East Freo?" And then their doctor was leaving. They were like, "Do you want to do it?" And I was like, "Yep." And I didn't know what I was getting into, and it was an amazing year. And I still, I have such fond memories of it. But you were learning on the run, and I remember one game that I was supposed to be working in ED at Freo Hospital, and the game was that day. It was a weekend shift, and I called in sick, and then hadn't looked at the schedule, and I realised that the game was at the Oval that was next door to Freo Hospital. And so I'm there, and I'm trying to make sure that, out of the windows, no one can see me, because, all of my mates are kind of doing their ward rounds, and I'm sick at home. And, just it's really fond memories of, doing these kind of early gigs where you're getting your first taste and realizing this is what you want to do. And working in sport is so much fun. But things like WAFL and these kind of these leagues that you're sort of building up into more professional and higher demands is a really nice way to do it. Because when I started at the WACA, that's a big step up in terms of expectations and in terms of consequences and in terms of what you're trying to achieve and what the implications are if things go right or wrong, and the stakeholders and all that stuff. So I think, when we talk to our sort of sports med registrars who are going through their training program, I think working through kind of those tiers of sports medicine are actually really important, so that when you get to a job that is kind of in that higher bracket and there's a lot more pressure and there's a lot more media and all these things, that you handle that well.
And I've heard great things about you from WACA from some of the players.
Oh, yeah. I saw you had Hask.
Yeah, we had Lask on,
yeah.
and that was pretty good.
Yeah.
Pretty popular episode, especially with the Indian demographic from the cricket side of things.
Yeah.
But you've just finished 7 years with them?
Yeah, 7 years with the WACA.
Great experience. Or?
So good, yeah, so good. It'll be very hard to top in my career of things that I'll reflect on and enjoy more. But that the WACA is I think it's a very unique place, and I've kind of done little bits and pieces, mostly sort of match coverage and stuff in AFL, and kind of done some of the WAFL stuff and other bits and pieces. But when you go into the WACA and you start to kind of integrate yourself into the day-to-days and as an organisation, it's like nothing else. So I was smiling watching that podcast you did with Hask and hearing him talk about it, because he's only come in the last couple of years and had a different journey to get there. But it's just, it's a real sort of family sense, and the players from my end, we spend most of our time delivering bad news. That's the shitty part of sports medicine, and particularly in professional sports, is that most of the time when I'm having sit-down discussions with players, it's about you probably can't do something, rather than, every now and then, yep, you're clear to return to play. But half the time it's really unfair, because half the time return to play, the physios kind of take in for their final session or whatever, they tick everything off, and I find out in an email that they've returned to play, got ticked off of the game on the weekend, and I don't get to kind of be part of the good news. But they're just such a good culture, and that it seems like that's been there for a long time, well before I was there, and I really enjoyed being part of it. And it's such a different, and I don't sort of know how much, I can't recall how much Hask got into the sort of cultural stuff in terms of game days and how they operate, but you go into a footy change room versus a cricket change room and how they prepare, and it's so different. It's so different. I just loved cricket, yeah.
We talked about that, the difference between the locker room right before a footy game to a cricket game, and depending on whether it's a T20 match to a shield match or a one-day match.
It's amazing, and in sports medicine, where we're always kind of intrigued on player preparation, and again, we're talking percentages of how you can get someone to high performance. And I always liked watching that contrast between T20 and shield cricket. Like shield cricket, you've got Hilton Cartwright sitting there doing a crossword, and the the siren's gone off to say that, players need to walk out, and he's rubbing something out. And it's just like, if you're doing that in an AFL game, you'd have your contract ripped up. But that's how he would mentally prepare and ground himself. And then you get into a T20 game, and it's like the intensity dials up a little bit. And the thing I love with working with Perth Scorchers and the WACA is that even when you're in that higher intensity bubble, it's still a very different beast, and there's still a really big emphasis on getting yourself into a positive space. And it's, that I remember covering, I was covering a game for West Coast, and I think the show called Vikings, and they had that like really intense theme music at the start of that, and that was playing in the change rooms. I was like, this is madness. Like, guys are like, banging their heads on cupboards and things like this. I was like intimidated, and deep heat's pumping around. You're like, footy. And then, T20, like, and some Big Bash games, they'll give me, because I'm kind of sitting there idle a lot of the time.
Give you aux?
Yeah, they give me the aux cord, and I'm in charge of setting the music.
What's the go-to aux song for a T20 cricket match?
So I get really, like, if I know there's a chance I'm going to be doing it, I get nervous, like more nervous than I do in my actual job, because the pressure, if you deliver a banger.
The social validation.
Oh, yeah. And all you need is usually you need to get Ashton Agar and you need Josh Inglis, and then they're kind of the gatekeepers of the vibe, because and they'll also shred you the most. So I put these playlists together and I kind of put it on, and I drift out of the room and I just peek back in just to see how the vibe's going in the room. And when you've missed and someone's saying like skip next, you're 20 seconds into your first song, horrible. Yeah. Like not crying, but like I feel bad about myself. Yeah. Yeah.
But when you hit the bangers?
Oh my God. When you get one and someone kind of like that look of surprise, they're like, oh, he's got one.
He knows what's up.
Yeah. And then, they'll go out and play a game, play well, and you'll be driving home. You're not thinking about, oh, medically did I influence that game? You're like, I think I got the vibe right. I think going back to that game, that R. Kelly that I played early, that was influential. Yeah. So.
Wait, well, I had one more question on the sporting side of things. How does one get into and do the World Ultimate Frisbee Championships?
Yeah. That was a strange couple of days. So that was in your training scheme. You have to. So we go, for people who sort of don't know medical structure. You go do your medical degree. You do internship, which is a year that you're sort of on a provisional registration, and then after that you become a resident. And then your resident years, you can kind of funnel through different specialties. And then when you pick your specialty and you get onto that training program, you're a registrar. And so in our registrar program for sports med, you have to cover like an event, and it has to be something that's kind of across multiple days and is a bit different. You can't do your cricket and your footy and stuff. So it's actually really hard to find. And somehow I found the World Frisbee Championships, Ultimate Frisbee Championships. Yeah, pretty niche, and they were in Perth. And so I somehow got myself involved, and I had no idea. And I just thought, this will be pretty straightforward. I'll just roll in. It was out at Waste, and I was like, I'll just roll in, and this will be a couple of days, tick it off, and I'm done. And it was actually amazing. They were incredible, and the intensity that these people were playing at. And like I had dislocated shoulders. I had some guy come up and ask me to strap his knee, and he'd blown his ACL, and he's like, I was trying to explain this to him, and he's like, mate, just strap it. I'm going back out. And I was like, oh, okay. Like, this is not what I was expecting. And they do that whole like layout, and they dive and fully outstretched, taking these, incredible catches. And yeah, I actually left it, and I was really surprised, but had a lot of admiration for it as a sport. Like it's intense and it's cool. And yeah, that was something that I wasn't expecting to put on the CV, but, yeah, it was good, and it's good fun. And sports med lends itself to that. Like every now and then, I remember last year I got an email from someone in the Bowls Association, and it was like, can you write us a heat policy? So now I'm, and he told me, I'm always welcome at the Bowls Association of Perth. And I'm like, that's kind of a cool thing. It was, stuff that you probably wouldn't normally channel yourself into.
Not for a few years anyway.
No. I think, once you go down that pathway, I think, you've reached a different phase in life. So if I'm, bowls in the next 2 years, something hasn't gone right. Yeah.
So you were just talking about the structure of it all with college, and you're the state coordinator of the Australasian College of Sport and Exercise Physicians?
Yeah, so I was. So that I've finished up last year, but that was something that I sort of held for a few years and really enjoyed, and it was part of, you go through these training schemes, and I think we all kind of go through it, and you're probably the same, in areas that you go into, but you want to be a good influence and a good change on things that you found didn't work well, or things that you were frustrated with. And so part of that for me was I wanted to help kind of refine the training scheme a little bit and change it up. And it's definitely come a long way. Like we as registrars, there was only a handful in the state, because it's also a tricky field to kind of apply your trade in, because there's not a lot of us. And I remember with my cohort I was going through with, we'd meet up on a Wednesday from 6 till 9 p.m. every Wednesday, and someone would be in charge of just doing a 3-hour PowerPoint. And it was hectic and it was a lot of work, but that was the only way that you were going to get taught some of the fundamentals that you don't roll into your clinic when you're working as a registrar. And it's now evolved to a point where, these guys, the registrars now, have got Australia-wide and New Zealand included, that they've got weekly tutorials from specialists all around Australia and New Zealand that dial in and give them talks, and it's all recorded and there's interaction, and it's really, really nice. But that was something that I was quite passionate about, is that I wanted to try and help influence that and grow it and make it better, because I came through and I felt like there was things that needed to be done, and you make little bargains with yourself that when I get through I'll change it. So I kind of like that sort of thing.
You've clearly developed quite a strong passion for sports medicine and helping out athletes, recreational versus professional. What's next? How do you see the future? It's too hard to tell right now.
Yeah, it is hard, and it's it's tricky. So I had this sort of conversation with Kate Harvey, our sort of my boss at the WACA, and when I was finishing, so I finished up at the WACA, and we had twin girls 18 months ago. And
congratulations!
And thank you. Yep. So that's kind of a big part of my life now, and one of the reasons why I stepped away. But it's hard, because I think, and certainly by the end, like my dream job at the top was working at the WACA. I didn't have a next step, and it was pretty unique to be in that situation where, like, I'm 37 and I felt like I was in the job that's what I wanted to do forever, and then different circumstances change, and life pivots and you go a different direction, and I'm in a strange space now where I've pumped the brakes, and I'm sort of working part-time and trying to be a good dad and doing all this stuff to help out at home, and work at the moment, probably for the first time in my life, is coming second, and it's a strange thing. A lot, it's big in medicine, I think, that we become very career driven. And this is probably the first junction in my life that's now parked into second, and I still love what I do, and I get a real kick out of working, but it's the first time that my phone doesn't go off. I'm sitting on my phone now, it hasn't vibrated, and that's very unusual when you're working professional sport, and there's always someone who needs something somewhere. So I don't know what that next junction is going to be, and do you go and start kind of looking into Rachel Harris, who I work with at Possum? She's an ex-Olympic swimmer, and she's going to the Olympic Games and working with the swim team and other bits and pieces, and doing some really impressive things, and that's a big passion project for her. So, as sports physicians, we've got those opportunities, so you might kind of look at that. But yeah, I actually at the moment have just found a nice little sweet spot where I'm less kind of drawn to the professional athlete, and I like working with people like yourself and working with people who you can make a big impact and make a lot of change into just kind of general well-being and keeping people moving, and I get a lot of satisfaction out of that. So yeah, at the moment that's kind of what I'm doing, but you never know, Ultimate Frisbee might come back, and I'm ready to lay out. Yeah.
So the pursuit of happiness, now that you've achieved what you wanted to achieve, has clearly shifted with having daughters. And
bizarre, like we're 18 months down the line, and it's, you definitely wouldn't have envisioned yourself in this situation if you sort of looked at my life 3 or 4 years ago. But it's one of those things, and you hear people talk about it cliched a lot, but your life does change, and your lens on what's important and what's not changes. So for me at the moment, what and what historically used to make me happy, and I got a lot of satisfaction out of, was helping, particularly, in the professional world, and you have an impact and you help someone and they go and blossom in their career. And I used to just love that. I love seeing people, even like a Haas going and making his debut, and seeing guys like Cooper Connolly go and have his big moment on the stage, and you get a real thrill out of seeing those guys go and achieve their dreams. And at the moment, that's probably now sort of slipping back in my priorities, and I get a lot of happiness and satisfaction out of trying to fuddle and muddle my way through being a good dad, and working out what that looks like. And there's no roadmap, and it's so like my skill set is so different. And my wife's amazing and she's very, very good at it. But at the moment, my challenge is trying to work out how do I impact that, and how do I stay present, and how do I make sure that I don't take certain things for granted, and all that sort of stuff, which is very, very different. But I'm actually I'm enjoying it. Like, it's pretty chaotic, and we've had a pretty hectic journey so far. But that's at the moment what's making me happy, is just finding those moments where you feel like you're doing a good job as a parent, and they're few and far between, because it's mostly screaming, but like, those little moments, and they're kind of the new memories that I'm laying down. So it's really nice.
Awesome. Well, congratulations, obviously, on all the success you've had so far, and wish you nothing but the best for the future and becoming a dad and doing what you love the most.
Yeah. Thank you very much.
Thanks for your time.
Cheers.